So for now, we're actually going to focus on recently approved therapies for ulcerative colitis, their evidence and practical considerations. So as we had mentioned earlier, you see the recurring theme that we've been having this boon of therapies available to us, fortunately. It gives us many more options for our patients. So infliximab was first approved for Crohn's disease in 1998. You see that there was a lag over the course of several years without any additional approvals. But then afterwards, we started to see an increase in the number of FDA approvals for different drugs, where we start to also see that this linear growth trend is now evolving into a more exponential increase. It can be quite overwhelming, I will admit. But this, at the very least, has given us multiple mechanisms to be able to address along the inflammatory pathways for IBD. So for instance, we've got the traditional anti-TNF agents such as infliximab, adalimumab, and golimumab. We also have our anti-IL-12/23 agents, JAK inhibitors, anti-integrins, and even a more novel therapy, a more novel mechanism that is, which is the sphingosine 1-phosphate receptor modulators, which prevent lymphocyte egress from the lymph nodes, thus preventing its circulation throughout the body and to the sites of inflammation. But let's talk about the more recently approved drugs. So in a not too distant past, circa 2022, we had upadacitinib, which was approved for the treatment of moderate to severe ulcerative colitis. The studies that were used to kind of demonstrate its efficacy were U-Achieve and U-Accomplish. Patients here were actually randomized in a 2-to-1 ratio to either receiving upadacitinib at 45 milligrams per day or placebo for the course of 8 weeks. And those who did not respond were actually enrolled in an open label extension for an additional 8 weeks. So thus you see the 8 or 16-week time frame there. Now what we see for the primary endpoint is that for clinical remission, U-Achieve and U-Accomplish show that upadacitinib to be superior to placebo for this endpoint. And the same was also said for the secondary endpoints such as clinical response, 2-week clinical response, no bowel urgency, endoscopic remission, and histologic improvement. As for adverse events, serious adverse events, and serious infections, we actually did not find any differences between upadacitinib or placebo in these studies. Now, patients from these studies who actually had responded were then randomized to the maintenance sub-study, where they actually received either upadacitinib at 30 milligrams, 15 milligrams, or placebo. And as you can see from this bar graph, that for clinical remission, that upadacitinib either at 30 or 15 milligrams was actually superior to placebo in the maintenance phase. And the same can be said for the other secondary endpoints, as well as when you look at adverse events and serious adverse events, where there was not much difference between upadacitinib or placebo. But when you start to drill down in terms of the serious infections, and you may recall, the discussion earlier about the use of, or the Shingrix vaccination, for instance, there was actually an increased uptick or signal of herpes zoster reactivation amongst those individuals who were assigned to the upadacitinib arms, but not in placebo. So from a standpoint of practical considerations for this drug, it's an oral agent that you will prescribe at 45 milligrams per day for the course of 8 weeks for induction, followed by either at 30 or 15 milligrams per day. Now, the FDA mandates that those who actually start on this drug must have had either a failure or intolerance to prior anti-TNF agents, such as infliximab, adalimumab, and golimumab. There is also a black box warning, and this is a carryover of class effect for JAK inhibitors. So its predecessor, a JAK1 and JAK3 inhibitor, which is tofacitinib, had actually found in their surveillance program a subpopulation of individuals who had an increased risk of venothromboemboli. And these were individuals who had rheumatologic conditions, above the age of 50, and had one or more cardiometabolic conditions. And as such, with this carryover, despite being a more selective JAK1 inhibitor, this black box warning applies to the class effect of JAK inhibitors. So it's warnings against serious infections, mortality, malignancy, major adverse cardiovascular events, or thrombosis. So you'd want to be more vigilant about your patients who are above the age of 50 and have one or more cardiovascular risk factors. Now let's say that you're going to start the patients on upadacitinib. What you would test for prior to initiation would be TB, hepatitis B, and CBC, which we would do for all the other biologic therapies anyway. You'd additionally want to check for the liver profile as well as lipid panel at baseline and at week 12. And as mentioned earlier, and hopefully not beaten to death, the fact that we should also check for like the history of chickenpox, prior immunization against VZV, and if so, do they have antibodies? And if not, then recommending the vaccination. Well, we've already talked a lot about the pregnancy considerations, so just as a reminder, contraception during and 4 weeks after the final dose of Upadacitinib. Now let's talk about the drugs that were just approved last year, 2023. So one of them was Mirikizumab, and this is an antagonist against the P19 subunit of IL-23, thus making it an anti-IL-23 agent. So other anti-IL-23 agents we have discussed thus far include like Ustekinumab, which is approved for both Crohn's disease and ulcerative colitis, as well as Risankizumab, which is approved for Crohn's disease. Although not yet approved for ulcerative colitis, there are some preliminary unpublished and promising data to show that Risankizumab would be effective for ulcerative colitis. So maybe next year, 2025 GI-Mellinkoff, we may be discussing that instead. So for this study, LUCENT-1 trial, which was an induction trial, patients were randomized in a 3-to-1 fashion to either receiving Mirikizumab 300 milligrams IV or placebo for the course of 12 weeks, and thereafter continued on for the maintenance trial until a total of 40 weeks. And in the maintenance phase, they actually received 20 milligrams sub-Q of Mirikizumab or placebo sub-Q. Now let's talk about the results. So for the induction or remission in this LUCENT-1 trial for Mirikizumab, it was found to be more effective than placebo for clinical remission, clinical response, endoscopic remission, and histologic endoscopic mucosal improvement. And when you think about it from the time of achieving symptomatic remission, we see that Mirikizumab was able to start separating itself from placebo at about 4 weeks. And when you look at it from the standpoint of change of bowel urgency, again, we see that Mirikizumab starts to differentiate itself from placebo at around 4 weeks. Let's talk about the maintenance. So for maintenance of remission in the LUCENT-2 trial, Mirikizumab was found to be more effective than placebo for maintenance of clinical remission, corticosteroid-free remission, maintenance of clinical remission, endoscopic remission, histologic endoscopic mucosal remission, bowel urgency remission, and whatever other additional remission endpoints you'd like to add to that. From the standpoint of safety, unfortunately, Mirikizumab and placebo were found to be relatively similar, except for one notation, which is that the discontinuation of placebo was actually greater than Mirikizumab due to an adverse event. Not really surprising. Placebo, you're not really receiving any medications at a time. So in terms of practical considerations, this is an IV medication given at induction at 300 milligrams at weeks 0, 4, and 8, and followed by sub-Q injections at every 4 weeks at 200 milligrams. You would also test for these prior to initiation, similar to what you would do for the other biologic agents. And as was mentioned earlier, despite maybe the lack of data at the moment for safety in pregnancy, we could potentially extrapolate from other anti-IL-23 agents, such as Ustekinumab, and at least the preliminary data seems to be kind of safe for use in pregnancy. And the company has also begun a pregnancy registry where either the patient or the healthcare practitioner could contact this number to enroll their patients who are pregnant while on Mirikizumab. Now let's talk about Etrasimod. So you may recall me mentioning earlier about the sphingosine 1-phosphate receptor modulator. I know that's a mouthful, but this mechanism actually prevents activated lymphocytes from exiting the lymph nodes to circulate throughout the body and then going to the sites of inflammation. In the study Elevate, there were 2 of them that were used to actually demonstrate efficacy. One was the Elevate UC12 study, which was a 12-week induction study randomizing patients to either Etrasimod 2 milligrams per day or placebo. And there was also the UC52 study where they actually randomized patients again to either 2 milligrams or placebo over the course of 12 weeks, and then following that for maintenance for the course of the 52 weeks. So this was a single dose of 2 milligrams per day compared with placebo. What they found at week 12 for clinical remission was that Etrasimod was superior to placebo in both the UC12 and UC52 studies for 12-week induction. And for secondary endpoints, we again see it to be more effective than placebo for endoscopic improvement, symptomatic remission, endoscopic improvement, histologic remission, as well as clinical response. Now, looking at it from the maintenance standpoint, so week 52, for clinical remission, we again see from the UC52 study that Etrasimod to be more effective than placebo. And also the same case can be said for secondary endpoints for endoscopic improvement, symptomatic remission, endoscopic improvement, histologic remission, as well as clinical response. And then some additional endpoints, again, showing benefit over placebo for sustained clinical remission, corticosteroid-free clinical remission, and 4 and 12-week corticosteroid-free remission amongst individuals who had already been on corticosteroid use. As for timing of symptomatic remission, analogous to what I had shown earlier with Mirikizumab, we see in the UC12 study that roughly around 4 weeks, we start to see a separation between Etrasimod and placebo for symptomatic remission. And from the UC52 study, however, we actually see it even earlier at roughly around two weeks. So we can say maybe around a 2 to 4 week time frame that Etrasimod is able to then kind of confer some benefit greater than that of placebo. From a safety standpoint, we see here in the UC12 and UC52 studies that for the most part, any adverse and serious adverse events were roughly similar. However, you may notice a little nuance here whereby the Etrasimod group may have slightly higher signal of a safety risk. And this actually is, if you drill down a little bit more to the data, you'll actually find that this is related more to like bradycardia or AV blocks. And in addition, there was actually also a signal for one person developing macular edema when compared to 0 in placebo for the UC52 study. So from the standpoint of practical considerations, this again is a 1-dose, 2 milligrams per day drug that you would administer at the time of induction or maintenance. And from the standpoint of contraindications, this stems from the safety signals I had described earlier. So individuals who actually had the Mobitz 2 or third-degree AV block, 6 sinus syndrome, sinoatrial node block, unless you have a functional pacemaker, this would be a contraindicated medication. In addition, if anybody who's had a 6-month history of a myocardial infarction, transient ischemic attack, or decompensated congestive heart failure requiring hospitalization, or class 3 or class 4 congestive heart failure. Now, if you were to start these patients on this medication, having passed the screening of contraindications, the testing considerations again would be the hepatitis B, TB, CBC liver profiles. But given the safety signals we had mentioned earlier, there's an EKG, ophthalmologic, and dermatologic examinations that would be recommended. Now, the company that actually manufactures Etrasimod has offered to help with the performance of EKGs to kind of decrease the threshold for initiation of this medication. And as mentioned earlier, we should also consider VZV vaccination in these individuals. Neera has waxed eloquently about the pregnancy considerations, so I shall not repeat whatever she said. So let's talk about injecting new life into some old drugs. Jenny earlier talked about the now approved sub-Q formulations of infliximab. And so I'll just very briefly talk about the sub-Q formulations of vedolizumab. So this one study that actually showed some benefit was actually the VISIBLE-1 study. And in these individuals with moderate to severe ulcerative colitis, they were enrolled into this open label study where they actually received initially some vedolizumab IV and then randomized to either receiving a continuation of the vedolizumab IV with a placebo control sub-Q or vedolizumab sub-Q every 2 weeks with a placebo IV or placebo IV and sub-Q. And what they found, very briefly again, was that for clinical remission, you see no difference really between the sub-Q or IV forms of vedolizumab, and you can see that they're also statistically greater than that of placebo, thus demonstrating the potential for vedolizumab sub-Q to be an alternative product for patients who actually are on vedolizumab and would like to actually switch to a more convenient sub-Q form. So what about maybe looking into the future, perhaps 2024 and beyond? So let me at least just share with you a phase 2b study that was published, the QUASAR study. Guzelkumab, by the way, is another anti-IL-23 agent. Patients were randomized to either receiving guzelkumab at 400 milligrams, 200 milligrams, or placebo. And what we see here is that for their primary endpoint of clinical response, guzelkumab at either the 400 or 200 milligram dose was actually superior to placebo. And for the secondary endpoints, the same can be said for guzelkumab versus placebo, except for endoscopic normalization, where there was not really as much difference when you actually had the higher dose of guzelkumab. Now, that's not to say it's not effective. Again, this is a phase 2b study, and they may not have been powered for that particular outcome. But these are preliminary data again. And in turn, I'll also present to you another interesting data point where patients who actually failed or did not respond to guzelkumab at week 12 were then actually continued on it for another 12 weeks, and they actually found that they could eke out an additional 50% response. So if you're to look at the bar graph to the right, you see that at week 12, there's about 60% response rate. And then when you go to week 24, you actually are then able to achieve approximately 80% response rate in these individuals. From a safety standpoint, it's roughly similar between guselkumab and the placebo dosing. So to wrap this up, let's talk about take-home points. So in the not too distant past, in 2022, Upadacitinib again was approved for use in moderate to severe ulcerative colitis. It's an oral drug, JAK1 inhibitor, second-line agent because they must have either failed or been intolerant to an anti-TNF beforehand. I mentioned about the black box warning, so you may want to be more vigilant in your patients who actually are above the age of 50 with one or more cardiovascular risk factors and even like a history of thromboemboli. And you may also want to check their VZV status and recommend VZV vaccination and contraception during use of this medication. As for those that were just approved in 2023, we've got Mirikizumab and Etrasimod. Mirikizumab, again, is an anti-IL-23 agent. For induction, you give it an IV infusion and then a sub-Q for maintenance, and it's likely safe in pregnancy. As for Etrasimod, it's that novel sphingosine 1-phosphate receptor inhibitor. It's a second in class. The other one first in class was ozanimod, and this is an oral medication that you would give daily. For pre-testing, you'd want to use an EKG, ophthalmologic and dermatologic examination, check for VZV status and or recommend VZV vaccinations, and keep in mind some of the contraindications such as MIAs, TIAs, CHFs, and I guess if we want to continue on those acronyms, AVBs, SSS, SA block, SAB, I guess, sinoatrial block, sick sinus syndrome, and atrioventricular block. And then for contraception, you would recommend that during and at least 1 week after its final dose. And then finally, let's talk about, so I just presented you some data on the newer drugs. We've got now some injectables for our oldie but goodies, the infliximab and belizumab. So more options for our patients. And then just around the bend, we've got guselkumab and a very robust drug development pipeline. So I think that in this day and age, just like what Neera said earlier, it's a very exciting time. I know it can be overwhelming to have this immense array of medications available at our fingertips, and how do you choose one versus the other? But the benefit in all of this is that one, it gives our patients a lot more options for therapies, particularly when some have contraindications versus the others. It gives us a lot of patients more choice for modes of administration and balancing out efficacy and safety profile. And then thirdly, it also gives us kind of hopefully more ways to be able to personalize our treatment regimen, but I think we need more biomarker studies for that. So with that, thank you very much.